Hello, my name is Haley Radke, and I'm getting on to talk about the adult case study. We are going to start off by talking about the information we were given on Mr. Johnson. Mr. Johnson is a 47-year-old male that was referred for a complete speech and language evaluation. Mr. Johnson is now medically stable after being involved in a drive-by shooting 1 month ago. He is a successful attorney and is married to his husband, Jim. His MRI shows damage to his entire left percivilian area, including the superior temporal gyrus, area of the triangularis, the inferior part of the parietal lobe, the arcuate fasciculus, and the inferior portion of the primary motor cortex. Given this information, the SLP will need to gather more case history information, assess, provide results, collaborate with other professionals, and provide counseling and resources if necessary. Before going to assess Mr. Johnson, due to the amount of damage the MRI shows, the SLP needs to be confident in her knowledge and understand the areas affected. Permanent damage to the percivilian region in the left hemisphere would cause a language impairment. The left temporal lobe and the parietal lobe is essential for comprehension, recalling information, and for formulating appropriate syntactic semantic structures. The posterior inferior frontal lobe is near the region known as Broca's area. Broca's area is essential for planning and organizing speech movements. The posterior language zone is what is known as the Wernicke's area, which is critical for storage and retrieval of words, word meanings, and knowledge of grammatical and linguistic rules. Wernicke's area receives input from the auditory cortex. The superior temporal gyrus contains the auditory cortex, which is responsible for processing sound. Broca's and Wernicke's area communicate by what is called the arcuate fasciculus, which is a band of nerve fibers. These band of nerve fibers delivers messages formulated in the Wernicke's area before it reaches the Broca's area. So damage to these specific brain regions would affect an individual's speech, language, and motor planning. Mr. Johnson could classify as aphasic due to his TBI. So we would have to look at different types of aphasia, and we would have to base his damages on what would be most appropriate aphasia-wise for him. And Mr. Johnson would most likely classify as having global aphasia, which is a severe form of non-fluent aphasia caused by massive damage to the percivilian region. Mr. Johnson most likely has global aphasia due to his traumatic brain injury. We would expect to see severe impairments in all language functions. Mr. Johnson will exhibit difficulty in listening, comprehension, answering yes/no questions. Reading simple words and sentences is non-functional, and speech is severely limited. Some strengths that we would see with Mr. Johnson is him being attentive, alert, task-oriented, and also very socially appropriate. Being well informed on the information provided will help us throughout the evaluation process. The SLP will need to work with the entire interdisciplinary team. The team will consist of the patient, caregiver, occupational therapist, physical therapist, counselors, physicians, neuropsychologists, audiologists, and nurses. The patients admitted into an inpatient rehab will be receiving therapy for at least 3 hours or more per day by varying disciplines. We'll be working collaboratively by formulating goals that can be carried across each discipline. Before the evaluating process, the SLP will need to reach out to other professionals to gather input on Mr. Johnson, if they are already working with him. So if they are already working with Mr. Johnson, it would be very essential to ask these professionals, schedule availability to be able to fit Mr. Johnson into your schedule without it overlapping with other professionals working with him. We also want to gather professional input. We want to ask them, what are the family's concerns? Are they concerned about his speech right now? Have they mentioned it? What have you seen? These would be important things to ask. That way we have an idea before we go in and evaluate Mr. Johnson. End goals we also want to ask in goals that we can help assist in with Mr. Johnson in achieving the highest possible quality of life. And that will kind of take more effect when he is in speech language services and also receiving other services from other disciplines. And we want to make sure that we're all working together to make sure that these goals that we are working on in treatment is being carried across each discipline, and that he is implementing them, and that he is understanding how to carry it over. So now that we have received additional information, we will need to schedule a time for the evaluation. The speech language pathologist will be responsible for bringing in required materials for the evaluation. Materials may include a computer with a computerized assessment, pen light, dry erase board, marker, notebook, and pencil. Upon entering the patient's room, we should always knock and start by introducing ourselves to the patient and caregiver. The SLP needs to be informative on why their physician referred them to a speech language pathologist. The SLP will explain to the family what her scope of practice is and how she can help them. During the initial meeting with the patient, it's essential that the clinician take observational notes and ask open-ended questions. Asking the patient and caregiver open-ended questions provides the clinician with necessary information to assess. And what I mean by that is open-ended questions can help the clinician kind of gear what she's going to assess. They actually really, really help assist professionals through the assessment process. So it's very, very important to ask those questions. Also, due to the limited amount of time that we are given in inpatient and outpatient to assess individuals. So that's very, very beneficial. The question should be geared towards the patient at the beginning of the evaluation. And we'll want to ask Mr. Johnson questions like, can you tell me your story? Can you tell me about your accent? Are you currently on any medications? What did you do as a living? How old are you? What are your concerns? Is English the only language spoken? Have you had any difficulties with swallowing? Do you have a hard time understanding people? Do you easily get frustrated? Why? Can you explain to me? And also, have you had any difficulty with hearing since your accident? We also need to keep in mind that Mr. Johnson may or may not be able to answer these questions. With that being said, the SLP will need to refer to his husband, Jim, throughout the evaluation process. However, we always want to address the patient first, and if he's having difficulty, continue to involve him in the conversation while obtaining further information from his husband. Jim's involvement is also crucial throughout the evaluation process. The clinician needs to keep in mind the state of mind that the caregiver may be in. They may be overwhelmed, depressed, anxious, sad, or in denial. I would ask questions such as, how are you doing? What are your concerns? Can you tell me things that have changed? What have you noticed that's different? Do you have any questions at this time? These types of questions will allow the clinician to see if the patient and caregiver have come to terms with the accident or are in denial. This will provide an opportunity for them to share frustrations and express their concerns. If the patient and caregiver are in denial, the SLP will need to be prepared to provide counseling and reassurance if required. It's essential that we consider cultural competence for the specific patients due to the difference in sexual orientation. The SLP will need to be aware of heterosexist language. Do not ask or assume gender of the person's partner. Do not ask if he has a spouse, and do not assume same-sex couples are married. It's also very important that the SLP revise wording used on clinical forms and records that include heterosexist language. So now it's time for the evaluation process, where we're starting to get into assessments. The clinician will be assessing many areas within our scope of practice, such as fluency, speech reduction, language, cognition, voice and resonance, feeding and swallowing, and auditory function. When gathering the case history information, the SLP is asking about those medical history, education, culture, and linguistic backgrounds, and if they've had current or past evaluations. And if you had noticed, I had asked if Mr. Johnson had had any hearing problems, and I was getting an idea. I was informally assessing hearing and kind of getting an idea if he is having hearing issues and I need to recommend him to an audiologist, and if he's not. So, asking him, have you had any hearing problems since your accident? Have you noticed any changes? Do you have any trouble hearing? Those are the questions that I would want to ask the patient and the caregiver. Earlier, I had mentioned that, there was materials that would be required for the SLP to bring in, and I did not mention standardized assessments. And I have changed this from my first paper to this one, just by going off of my experience of working in a hospital and kind of going by what I did when I worked at Integris. And most hospitals, outpatient and inpatient, they do not have access to standardized testing materials. The hospital will create their own computerized informal assessment to determine qualifications of services and treatment goals for patients. So most computerized informal assessments include expressive and receptive language, cognition, social aspects of communication. The clinician will use a computerized informal assessment to assess Mr. Johnson's orientation to person, place, and time, yes/no questions, following directions, clock drawing tests, problem solving, categorization, confrontation, naming, time management, math problems, immediate and delayed memory recall, and comprehension questions based on a paragraph that is read to them. The clinician noted difficulties with Mr. Johnson in answering complex and basic and complex yes/no questions, understanding speech, misspelling name and address, confrontational naming, inability to comprehend questions, and inability to speak. Assessment of articulation and phonology is essential due to suspected apraxia or dysarthria. This will be obtained through conversation with the SLP, as well as naming various pictures, objects, and repeating a variety of words and phrases. An oral examination and altering motion rates will also be completed. An oral examination includes examination of the mouth, jaw, teeth, lips, tongue, hard and soft palate. The clinician will also be looking at altering motion rates, which is pa, 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 ta, 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 ka, 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 pataka, pataka, pataka. The clinician is noting strength, speed, and movement of articulators. Speech motor planning is also being looked at, which is the clinician is looking if the patient is able to come up with an idea, express it, and say it. The clinician noted the inability to control his muscles used to form words, trouble imitating and saying sounds, inconsistent errors, and groping. The swallowing assessment will be completed to determine difficulties with feeding and swallowing, what stage does it occur, and what types of food and liquids are safe for the patient to consume. The clinician will be performing a non-instrumental assessment or a bedside swallow. We will want Mr. Johnson to be sitting upright in his bed for this part of the assessment. We will be trialing sips of water through straw and cup, thickened liquids, and foods such as crackers, applesauce, and fruit cups, which is offered in hospitals. The clinician will be noting symptoms like drooling, coughing, choking, and if the patient has difficulty swallowing solids, liquids, and another important one is pills. The clinician noted swallowing problems with Mr. Johnson due to the motor deficits and the risk of aspiration while eating related to the impact of cognitive impairment. It will also be recommended to complete a modified barium swallow study. It would be essential to observe initiation of the pharyngeal swallow, soft palate elevation, laryngeal elevation, anterior hyoid motion, epiglottic movement, laryngeal closure, and esophageal clearance. The clinician will assess voice and resonance by using the conscious auditory perceptual evaluation of voice, which is called the CAPE-V. The CAPE-V is looking at severity, roughness, breathiness, strain, pitch, and loudness. The clinician will record Mr. Johnson's performance and ask him to complete 3 tasks. And those tasks are vowels, sentences, and conversational speech. And this is really essential because assessment of voice and resonance helps to differentiate apraxia and speech from dysarthria. The clinician did note dysphonia, which was resulted from intubation. Fluency will also be informally assessed while completing the CATE-V. If the clinician notes stuttering and cluttering, she will use the recorded conversational sample. The conversational sample will be listened to and transferred to a speech sample grid. This will help us to understand the types of disfluencies or fluencies the individual has demonstrated. The clinician will use abbreviations to distinguish the difference between fluent and disfluent. The abbreviations correspond to different kinds of disfluency types. The grid will help us determine stuttering types such as part word repetitions, sound prolongations, and blocks, and non-stuttering such as revisions, whole word repetitions, interjections, and phrase repetitions. Mr. Johnson's fluency was observed to be within normal limits at this time of the evaluation. Lastly, we also need to consider if a communication modality is necessary or if it needs to be considered. A communication modality is a different way other than using speech to communicate. We will use gestures, sign language, facial expressions, writing, drawing, and low and high-tech devices. Throughout the evaluation, the clinician provided the patient with a variety of ways to communicate. The SLP pressed Mr. Johnson to utilize his voice. Due to him being non-fluent, we really want him to try and speak. So we pressed him to use his voice, but we also incorporated a dry erase board and notebook to minimize frustrations. At the conclusion of the evaluation, the clinician will discuss results with the patient and caregiver. The discussion will involve the diagnosis, observation, and recommended plan of treatment. The clinician will also be recommending if Mr. Johnson needs to see other professionals and if speech-language services are warranted at this time. This will also provide an opportunity for the patient and family to ask any questions after the speech pathologist, diagnoses Mr. Johnson. For Mr. Johnson, it is recommended that the patient receive speech-language services at this time to assist with increased independence for functional tasks across all settings. It is recommended that Mr. Johnson focus on his cognitive communication issues, expressive and receptive language skills, apraxia, and dysphagia. Mr. Johnson will partake in 3 hours of therapy or more per day until discharged to outpatient rehabilitation. The goals that will be addressed are: patient will accurately answer yes/no questions, given moderate cues with 80% accuracy. Patient will increase confrontational naming and functional problem solving. Patient will perform various short-term and working memory tasks. Patient will correctly carry out non-speech oral movements. Patient will correct articulatory placement of sounds and words. And patient will learn and perform 10 to 15 basic tongue compensatory strategies. And it's also important that the patient and caregiver will demonstrate an understanding and utilization of compensatory strategies. And also with the Mr. Johnson partaking in 3 hours of therapy or more per day, it's not 3 hours of speech therapy. It will be 3 hours amongst all disciplines. So it will be about an hour per day for speech-language services. Speech-language therapists working with TBI patients in rehab are faced with several challenges in delivering evidence-based practice services to patients. Insurance may deny coverage or cognitive rehabilitation or limit the number of sessions that limit treatment. There is not one effective evidence-based practice that is appropriate for TBI patients. Communication disorders require an interdisciplinary approach to treatment that involves all professionals. The evidence-based treatment approaches we would include are compensatory and restorative therapy approaches. Restorative intervention helps to repair compromised cognitive communication processes by drills to stimulate or rebuild damaged neural networks. The compensatory intervention will provide compensatory strategies by training specific daily life tasks or by modifying the environment. So throughout treatment, we will be using these approaches. Activities will include the SLP and the patient working on confrontational naming, so providing cards and going through and having him name those picture cards. It can be done on using just picture cards. It can be done on an iPad if the clinician has an iPad available. Answering basic yes/no questions. So these, what I mean by basic is, can the patient answer, questions like, are you married? Do you have children? Do you have brothers and sisters? And we want to make sure he consistently answers yes, no questions. That way, that will be a good way of communication for Mr. Johnson. Automatic language. What I mean by automatic language is having him sing happy birthday songs, days of the week, and counting. Can he say his whole name? Can he tell you his birthday? Those are all very, very important things to work on. Following directions. Can Mr. Johnson listen to verbal directions and point to your nose, point to your ear? Can he point to his own body parts? Basic categorization. Can he categorize farm animals in comparison to zoo animals? And if it's really basic, name as many animals as you can. And that might be actually a little hard for him right now, but it's something that we can work towards. Repeating words and phrases, having the clinician say or imitate a word and then having him repeat it. Recalling and discussing family members, hobbies, and interests. With adult patients, it's especially a patient with global aphasia, having them recall and discuss about family members and their favorite hobbies. For Mr. Johnson, that might be centered around his job, his place of employment. He was a successful lawyer. In interest, he might have a lot of interest, maybe fishing, or he loves sports. This will be very, very important to incorporate throughout therapy. It makes it fun and it makes it interesting, and it's about the patient. The clinician will implement speech strategies, and this is for apraxia, such as slowing down, paced speech, and overpronunciation. We will want to repeat sounds over and over and over and over again, and practice correct mouth movements. So maybe the clinician will, show that, and he will follow the clinician. Swallowing exercises will include the Masako maneuver, gauze exercise, effortful swallow, and gargle exercise. These will be very, very important for Mr. Johnson. We will practice these exercises daily with repetition of each exercise using a mirror. That way he can see what he's doing. Modification to texture of food may be implemented to allow for safe oral intake. The clinician will consult with the dietitian to ensure nutritional needs are met. It's essential that we also provide skilled training for caregivers. It will help the patient's spouse to facilitate everyday communication with his husband. The main goal is to achieve the highest level of participation across all settings. It's also important that with Mr. Johnson, and especially his family, that we provide information. So providing visual information on what is global aphasia, talking about that, bringing awareness to him would be very, very important so he understands what's going on and why he's having a difficult time. Will be very, very important. I also have the tongue-based strengthening exercises that I had mentioned. So we have the Masako maneuver, which is placing the tip of your tongue between your teeth and gently swallowing. And we want to keep your tongue in between your teeth. This is strengthening muscles in your throat. So he's going to do that 10 to 15 times. We'll start with 10 and we can work up towards 15. We have the gauze exercise. Place a rolled piece of gauze between your front teeth and gently hold the gauze in place and swallow. So holding something in front of your teeth and swallowing. We have the effortful swallow. Swallow your saliva while you sneeze. All of your mouth and neck muscles very hard. So the effortful swallow is holding that saliva, swallowing, and coughing is what the effortful swallow is targeting. And then we also have the gargle exercise. So pull your tongue as far as back in your mouth as you can and pretend to gargle. So that's another one that we could work on with Mr. Johnson. And this is a great handout that is a visual that we could have up in his room that he could practice every day when he's not in speech as well. So that is also really great. I had mentioned categorization, animals, can you name as many fruits or vegetables? That might be a little hard for Mr. Johnson right now. Maybe he could do some categorization with some pictures. If I did so many pictures out, could you categorize them on the table? Verbally might be a little hard, especially if we're doing it in under 1 minute. For memory, playing with the deck of cards is a lot of fun. You can tell stories with cards. You can have them sequence those cards in the correct order. It's just a fun way for memory. I have 2 memory books that specifically target everything that I would do with these and the patient and what type of memory it is addressing. And lastly, we want to make sure that we are implementing, because I had said that I had incorporated some type of another way of communication besides speaking, and that was a dry erase board and a marker to minimize frustration. And some people don't really like dry erase boards. They prefer pen and paper. So also providing a notebook would be great. In that way they can write things down. You can work on his writing so he can communicate through pen and paper or on a dry erase board. So that would be very, very beneficial to also include in treatment. Assistive technology requires an interdisciplinary approach by a trained speech-language pathologist, occupational therapist, and physical therapist. Few studies address AT usage by individuals with TBI. AT would be beneficial for a range of communication disorders. The only thing is the SLP will need to evaluate the effectiveness of AT and the interventions designed to help patients develop these skills. Unfortunately, for Mr. Johnson, insurance would not approve of an AT device due to the lack of therapy and progress data. However, the SLP could implement the use of external memory strategies, and that is low-tech and high-tech. So for low-tech, we could incorporate memory books, which are picture-based calendars, planners, organizers, lists, and alarms. For high-tech, we could use his phone, computer, iPad if they have that available. It would also be essential to involve the husband in building a picture book of family members, friends, and items of interest. And we want to make sure that we ensure that we are giving him some type of communication modality, whether that's gestures, facial expressions, consistent yes/no questions, that way that he feels that he can communicate and there's no frustration there. Strong feelings accompany patients with communication disorders and their families. Communication is something that comes naturally to us, so when it's taken away, people become emotionally upset and depressed. So being the barrier of bad news, we need to be considerate of their emotions and not push them over the edge, not bombard them or give them too much information. So we will need to employ all sorts of strategies to prevent those from those feelings emerging. I think to use, when I was working with adult patients, I think to use a sense of humor as a distraction to try to make people feel better or laugh. It helps to lighten the mood, and it gets them to focus on treatment, and it also brings smiles to their face, and it just gets them to laugh. And this is essential to provide. It's essential to provide a lot of education to keep people in their cognitive realm and away from letting their mind wander. So providing information on aphasia and providing information on dysphagia, drawing out, the swallowing mechanism, even if it's just a picture of, this person's throat, and drawing that in and showing them why they're having issues. Providing that education and handouts is very important because it does keep them in that cognitive realm. And it's also important that we assure our patient that it's normal to feel the way that they do, and that they're starting on the right track by being here and working with all of the disciplines. We don't want them to make them feel guilty about their feelings. As their clinician, we need to be willing to acknowledge these feelings and most importantly listen. By doing this, we are starting the healing process and implementing treatment along the way. I hope I covered everything. I know it's a little long. I wanted to make sure that I involved different options that I would use in treatment with Mr. Johnson, but thank you very much.